Hello everyone, this is Dr. Hasna brought to you by UKPass Academy, and today we're doing the Inguinoscrotal swelling examination, or you can say this presents as a teaching station. So that's what I'll be going through. Now, first things first, before we talk about Inguinoscrotal swelling, how to teach it. First, how about I teach it to you so that you know the right things to say when a student or any junior comes to you to talk about it, right? So the first thing is to understand what is the inguinal region, alright? So it starts with the most important, you can say, landmark, which is the pubic tubercle, which is right in the groin area, alright? From the pubic tubercle, and then there is another landmark right over here on your waist. This is called anterior superior iliac spine, alright? Anterior superior iliac spine, pubic tubercle are two things that you can actually feel on your body, so we call them the landmarks. I absolutely love anatomy, so I'm absolutely enjoying this. Alright, so first things first, the most important thing is to understand there is an inguinal ligament that runs between the two inside our body, alright? So if we ever were asked what is inguinal ligament, we know it runs from here all the way to the pubic tubercle. Now, remember some measurements, okay? First measurement is just ½ inch above the pubic tubercle lies an opening, and it lies medial and above to the pubic tubercle. This is known as the superficial inguinal ring. And then the midpoint of inguinal ligament is the second landmark, above which lies ½ inch above is the deep inguinal ring. Alright, so this is the main concept. Now, running between the deep to the superficial inguinal ring is a passage called inguinal canal. So this is what you need to understand when you talk about the inguinal region. Why is this inguinal canal important? It's because this is where all the hernias, it's the point of weakness from which abdomen contents can leak into your genital area. Alright, the next important thing you need to know, just below lateral to the pubic tubercle is another opening which becomes site for femoral hernia. So you should know difference between inguinal and femoral. Inguinal means it's going towards your, it's a loop of bowel going towards your genital area. Okay, and femoral means it's going towards your lower limb. So any patient comes with any swelling in their body, we need to differentiate, especially in the groin area, we need to differentiate whether it's inguinal or whether it's femoral hernia. Basic. Okay, next there are two types of inguinal hernia. One that comes direct, one that comes indirectly. It comes indirectly. Why? Because it comes through, let's suppose guys, this is deep inguinal ring and the loop of bowel high, okay? So, and the loop of bowel that moves through the deep inguinal ring, yes, I can see the groin right there. And then I go through the, suppose this is the superficial inguinal ring, I leave and now I'm in the groin. This is a indirect inguinal hernia. It shows the indirect long pathway. And then there was a loop of bowel that was very smart. He's like, explain by the way. Alright. One of the hernia is direct. It says that, how stupid is he? Just break this wall, go through superficial inguinal ring, I'm in the groin. Why did you choose such a long pathway? So this is the difference between the two hernia. One comes from the deep inguinal ring, exit through superficial. One comes directly from the back of this inguinal canal, breaks it, and enters through the superficial inguinal ring. All in all, both are leaving, exiting through the superficial inguinal ring. One is coming through, indirect is coming through deep inguinal ring, other is coming through Hasselbalch triangle, which is not the deep inguinal ring. So now that we know these facts, it can help us a lot in differentiating the two types of hernia, okay? So this we've understood. The next important point to understand in this is, can you pause? Well done if you've come this far and you've understood the anatomy of inguinoscrotal region. Now all we need to do is teach it. Alright, so what we're going to do is whenever the teaching station comes, what did I teach you guys? Always begin Rapo, the 4 W's, and then the basics. This is how you're going to go about all teaching station. This is a structure. Structure is very important. So Michael comes to you, Michael says, teach me this. Alright, so you're going to go through the 4 W's. Alright, how are rotations going, Michael? How is everything on your end? When's your exam coming? Alright, I understand that you want to learn about the inguinoscrotal swelling examination or whatever it is. Yes, I do. Alright, so you go through the what already, that's the first W. What do you already know about it? I know this is. What do you want? So what already, that's how it goes, alright? Then it's why would you, is there any particular reason you want to learn it, and when do we do it? Alright, so you ask all of this. Now, according to what the student asks you is what you are going to teach. Either he will say, could you teach me the anatomy? And what are you going to do? Exactly explain to him what I explained to you, but in your own words on a paper. If he says, I want to learn the inguinoscrotal examination, I don't understand how to do it. This is what you are going to do. Alright? in both cases you will begin with the basics. Alright Michael, first things first, do you know what a hernia is? No, what is that? Okay, hernia is any kind of organ coming into another organ's territory where it is not allowed. Something like that. So the simpler you make it, the better you score. Alright, so hernia is, if you're talking about inguinal hernia, it means that it's loop of bowel, which is abdominal organ, coming into groin through the inguinal canal. Okay, so you teach him that. Alright, then you just quickly go through a brainstorm. Do you know what do you know where the deep inguinal ring is? Do you know where superficial ring? If he knows these things, that's great, because he wants to learn at the examination. But if he said, I want to learn the anatomy, then you teach him all of that. I hope that makes sense. But always begin with basics. What is a hernia? Do you know what a hernia is? Do you know how to differentiate between the inguinal and femoral? Now, let's talk about the examination. So you tell Michael, or you tell the student, is that whenever you begin an examination, what did I teach you all? The E square, C square and P square. Always explain, take consent, privacy, chaperone, and expose and position the patient. So in this case, for inguinoscrotal, you'll ask the patient, Michael, to expose from his mid-waist to his mid-thigh, removing his undergarments. Because ideally for inguinoscrotal, we need the abdomen, we need the genital area, and we need the lower limb to examine, because it can be a femoral hernia. It could be a groin inguinal hernia. It could be a hernia inside the abdomen. Alright, are you following me, Michael? Good. So once you've done the E square, C square, P square, you go for the examination. First things first, all of you know the best position for inguinoscrotal is standing up. So you ask the patient to stand up and do nothing but, what did I teach you for examination, guys? IPS, inspection, palpation, special tests. So inspection, but you will also add on a cuff inspection for case of hernias, right? So you're just going to ask the patient, Michael, that, you know, just stand up for me, I'm going to have a look. If you see an obvious swelling, that's great. If you do not see a swelling, you ask the patient to cough and see if there's a swelling. The moment you have seen a swelling in the inspection part, for instance, in the inspection, I have seen a swelling. What do? Start describing, start commenting on the size, shape, overlying skin, any other changes you can see that are obvious. Alright? Now, the next step is that once seen the swelling, you ask the patient to reduce the swelling himself and lie down. When the patient lies down, could you bring it closer? When the patient lies down, the fact that you know the landmarks, you know that this is the anterior superior iliac spine, this is the pubic tubercle, just above the midpoint, we know that this is the deep inguinal ring, right? So because we know this, we will be like, Michael, after he reduces, you ask Michael to remove his hand and you press over here on the deep inguinal ring. Ask Michael to cough. This is called deep ring occlusion test. If he coughs and the swelling comes out despite you putting pressure over here, it is most likely a direct inguinal hernia, because it came out through superficial inguinal ring. It did not need the deep inguinal ring. But if it does not come out and you feel a pulse on your finger on the deep ring, it's a indirect inguinal hernia. As you're talking, most likely your student will also be answering, and student will be like, yes, it's this, and then you just go like, excellent, wonderful, brilliant, Michael, you're doing a good job, well done, Michael, you're doing a good job, well done. Have all these words prepared. I'm a good teacher, that's why I remember. No, I'm not praising myself. Moving on. So this is the deep ring occlusion test. Now, for instance, next thing what you need to do is palpation. Palpation, I've always taught you guys that palpation should always include beginning with temperature, then tenderness, right? So first, over the swelling, you check the temperature, compare it with mid-thigh, compare it with the abdomen, up to you. Next, you check for tenderness. You look at the face of your patient and you palpate. Is there any pain? Alright? So if there is pain, Michael, tell me, why would there be pain? Most likely strangulation, right? So these are very important things to do. Next, after this comes the special test. Special test goes like, if you were unable through this whole time, you were unable to see any swelling and you were not able to palpate any swelling, what do you do next? You perform the Siemens test. So Siemens test is performed when you cannot feel any swelling, not in inspection and not in palpation. That's when you perform the Siemens test. What is Siemens test? Siemens test, if you could bring it close, yeah. So what you do is you identify three regions. One is the superficial inguinal ring, one is the deep inguinal ring, and one is the saphenous opening. All three have different hernias. So you use your 3 different fingers, approach from the right of the patient, putting index finger on the deep inguinal ring roughly. Your middle finger will lie on the superficial inguinal ring roughly, and this will lie on your saphenous opening. Okay, now what you're going to do is you're going to ask the patient, after you do this, you're going to ask the patient to cough. If you feel just even a pulse in your finger, this is deep inguinal ring finger, it's a indirect inguinal hernia. If you feel pulse in middle finger, it's a direct inguinal hernia. If you feel a pulse in the saphenous opening, it is a femoral hernia. So, Michael, how do you differentiate between inguinal and femoral hernia? You can add that point in. Inguinal is above and medial to the pubic tubercle, whereas femoral is below and lateral. This is basic anatomy. This is something I'm sure all of you will remember. You can poke this in, okay? Make sure you add it on. So, Zeeman's test is that's how you perform it. Alright, so pause. This was the case if you did not feel any swelling. What if you did see a swelling, you palpated a swelling? What do you do in that case? You just do the further special test, which is percussion and obviously auscultation. So what you need to get through is whether it's a we need to know what loop, what is the content inside that hernia or that swelling. So you have to feel its consistency firstly. Obviously, if it's a dull consistency, you obviously did it in deep palpation. You feel it. If it's like a doughy, it's a omentum. It's not abdomen. It's not intestine. But if you feel elastic, it is intestine. Okay, elastic is like tube-like. So that's okay. Next thing you do is percussion. You percuss over the swelling. When you percuss, note is resonant, means air. So it's intestine loop. If there is dull, it is omentum. Finally, you do auscultation. If you hear sounds, then it's most likely loop of intestine. If you don't hear sounds, it's probably omentum. So these are conclusory, if that's a word, conclusive steps of the examination. Alright, so this is all you need to know about the inguinoscrotal examination. At this point, always remember to, in your case, include the red flags, because you have to be a safe doctor at the end of the day. So you tell Michael that, Michael, just remember that you should know the signs of strangulation, and if you do see them, you have to immediately take him to hospital. Okay, so what are the signs of strangulation? Michael, go ahead and tell me, and then he'll say something and then you'll add on to it. You don't hear any bubble sounds, it's irreducible swelling. On palpation, you feel like the patient is very tender on it, and there's some overlying maybe skin changes, maybe he's having constipation. All of these are signs you have to send to hospital immediately. And that's it, Michael. Make sure you cover up the patient, you thank the patient. That's how you conclude your inguinoscrotal examination, and that's how you teach it as well. So these are all the steps I've taught to you. There are 2 approaches to teaching inguinoscrotal. Either he can ask you for the anatomy, either he can ask you for examination. So make sure, because obviously this is a very long, long whole case. Make sure you teach him what he's asking for, not extra. If he's asking examination, don't go into anatomy too much. Just brainstorm him about anatomy. But if he's asking anatomy, then teach anatomy. And if he asks the tell me examination only, then go to examination. Alright, so this is how you will conclude it. Alright, so that's all for inguinoscrotal. Thank you all for watching. Stay tuned.